Hi, thanks for joining us for this webinar. I'd like to introduce Dr. Mike Murphy, who is an expert in the analysis of volatile organic compounds in exhaled breath and the applications of breath biomarkers in respiratory disease.
Thank you for the introduction. In this webinar, we'll give you an overview of the science behind breath biomarkers and explain how breath analysis can be incorporated into your own clinical trials. As illustrated here, simple breath tests could soon provide doctors with valuable information to aid the diagnosis, monitoring, and treatment of respiratory diseases. Every breath contains thousands of volatile organic compounds, or VOCs. We'll explain the origin of these VOCs and why they are promising non-invasive biomarkers for a wide range of respiratory diseases. We'll show you how breath biopsy is being used to address fundamental challenges in the respiratory field, including the development of improved diagnostics to identify disease subtypes, enabling precision medicine, and moving towards identifying treatable traits so that the right patients can get the right drugs at the right time. Applications for breath biomarkers have already been demonstrated in a wide range of respiratory diseases, including asthma, COPD, idiopathic pulmonary fibrosis, tuberculosis, lung cancer, mesothelioma, aspergillosis, and identifying concurrent infections in diseases like cystic fibrosis. For example, GSK have already integrated breath biopsy into a phase 2 clinical trial for a novel drug candidate targeting COPD in the respiratory disease pipeline, both to assess the treatment effects of the drug and to investigate whether breath biopsy can help identify the right patients for the right treatment. We've put together some case studies on breath biomarkers in respiratory diseases, which you can read on our website. Later in this webinar, I'll present some data specifically on VOC biomarkers in asthma and COPD and discuss some of the applications for breath biomarkers, such as disease phenotyping and precision medicine. So what are VOCs and where do they come from? The thousands of volatile organic compounds in exhaled breath are fundamentally metabolites produced by the body. Endogenous metabolites are the end products of gene transcription and protein expression. What makes metabolites very interesting as potential biomarkers is that while our genome can tell us about the risk of getting disease, it is our downstream metabolism that gives us the best real-time snapshot of what is actually happening now. As such, the identity and concentration of metabolites provides relevant information about actual disease activity, because they most closely resemble the phenotype of an individual. It is worth bearing in mind that as well as endogenous metabolites, breath also contains volatile compounds from our exposome, the food we eat, the air we breathe, the medications we take, our lifestyle, as well as our microbiome. All of these factors together means that the VOC profile in our breath reflects our phenotype closely, providing a detailed and comprehensive insight into how the body is functioning. When the body's state changes, VOCs are well suited to detect these changes early, providing insight into the underlying processes that drive this change. VOCs in exhaled breath are valuable biomarkers for respiratory disease because they originate both from the local tissues and microbiota, as well as the wider body and environment. These diverse origins of VOCs in breath provide increased information about different diseases and conditions. For example, first, VOCs from lung and airway tissue directly reflect the local cellular metabolism, which includes cells connected to inflammatory processes and/or the immune response. Second, exogenous VOCs from the local microbiome and from the environment provide information about infections and about exposures such as smoking. And third, breath also contains VOCs the lungs have efficiently exchanged with the circulating blood. These can provide important information about the systemic effects of respiratory diseases, as well as the patient's response to medication. Our breath biopsy platform enables the robust, reproducible analysis of VOC biomarkers in breath. Once every minute, your entire blood volume circulates around your body. Every minute, then, VOCs originating from throughout the body pass efficiently from the blood and into the exhaled breath. Our breath biopsy platform continuously samples breath over this time period, collecting VOCs originating from throughout the body, as well as VOCs produced by local airways tissues and the microbiota. The key thing is that with each exhalation over this time period, we trap and store these VOCs, pre-concentrating them onto sorbent tubes for later analysis. This gives us unparalleled sensitivity for detection of disease biomarkers. I'd now like to discuss some of the opportunities breath biopsy offers for diagnosis, phenotyping, and treatment selection, taking asthma and COPD as examples. One of the major challenges of these diseases is a lack of stratifying diagnostics. Current guidelines advocate a trial and error approach to treatment selection, resulting in increased healthcare costs, prolonged periods of poor disease control, and an increased risk of exacerbations. So there is clearly a need for improved biomarkers to enable treatment to be tailored to the individual. The treatment of asthma and COPD can be challenging because they include a number of overlapping complex phenotypes. Symptoms are very similar, but the treatment required is not. The chronic airway inflammation has diverse origins and triggers, and can be broken down into a range of different subtypes of pulmonary inflammation. These inflammatory subtypes can be further divided into different endotypes, with different underlying molecular mechanisms or responses to treatment. This poses considerable challenges for disease management in the clinical setting. To address this underlying heterogeneity, there is now a considerable move towards precision medicine. For instance, the 2017 report, After Asthma, Redefining Airways Diseases, by the Lancet Respiratory Asthma Task Force. The goal of precision medicine is to identify different disease endotypes or treatable traits, enabling the right treatment to be given to the right patient at the right time. Of course, precision medicine requires the identification of robust biomarkers, which can reliably identify different disease endotypes. There is also an understanding that these biomarkers must be minimally invasive and able to be monitored easily in the clinic. Metabolomics is already being used as a tool to investigate pathophysiological mechanisms and discover novel biomarkers for respiratory diseases. For example, in asthma, metabolomic analysis of serum samples has identified differences in the metabolic profile of individuals with asthma compared to healthy controls, even in steroid-naive patients with mild asthma. The differences shown in this case relate both to the severity of the disease and also to the steroid treatment. Breath biopsy enables you to analyze volatile metabolites in exhaled breath, providing a new approach to characterize different disease endotypes. An increasing body of evidence shows that VOCs in exhaled breath are promising biomarkers that relate to metabolic changes caused by inflammation of the airways, demonstrating that breath biopsy is a valuable approach to discover novel biomarkers for respiratory disease. One breath-based biomarker, fractional exhaled nitric oxide, or FeNO, is already being used to support asthma diagnosis. FeNO reflects a protective biochemical pathway of the lungs, but lacks specificity, as it is a single biomarker affected by many processes other than asthma. We've examined the ability of VOCs analyzed using our breath biopsy platform to discriminate between asthmatic and non-asthmatic patients. As you can see, even in a heterogeneous clinical trial population, which included individuals of a wide variety of pulmonary conditions, the VOC profile discriminates well between patients with or without a diagnosis of asthma. On the right, you can see a study that compared the performance of exhaled VOCs with established approaches, such as FeNO and pulmonary function tests. The results demonstrate that the information-rich VOC profile outperforms these tests in discriminating asthmatics and healthy controls. Furthermore, combining VOCs with FeNO gave even higher diagnostic performance. While the diagnostic power of breath VOCs could provide a valuable tool for clinicians, even greater impact to the treatment of asthma or COPD is likely to come from disease phenotyping by characterizing underlying inflammatory subtypes. Correct identification of disease phenotype has become even more important with the approval of biological drugs targeted at specific inflammatory subtypes. This study by Ibrahim provides evidence that VOC biomarkers in breath correlate with different inflammatory subtypes in asthma, as defined by sputum cell counts. Using biomarkers to characterize asthma subtypes has so far not found widespread adoption due to the invasive nature of procedures such as bronchoalveolar lavage that are currently used to collect inflammatory cells for identification, and due to the limited applicability of phenotesting. This is where breath biopsy could bring real benefits to patients, as its non-invasive approach should be more acceptable compared to more invasive procedures. What's interesting is that there is a correlation between the breath VOC profile and the activity of inflammatory cell subtypes. For example, in the study of COPD patients by FENS, a VOC signature in breath correlated with the eosinophilic cationic protein, or ECP, which is produced by eosinophil cells as part of their inflammatory response activity. In the same study, a different VOC signature was highly associated with myeloperoxidase, or MPO, an activity marker of neutrophilic cells. This illustrates how differences in breath VOC profile between cases and controls are linked to differences in the activity of inflammatory cell subtypes, underlining the fact that VOCs directly reflect current disease activity. Another important aspect of the asthma phenotype is the degree of disease control. The profile of VOCs in exhaled breath can be used to distinguish between patients with controlled and uncontrolled asthma. Here you can see data from a subpopulation of individuals participating in a larger clinical trial. Exhaled VOCs were profiled using our breath biopsy platform, and we were able to build a classifier which could correctly identify individuals with self-reported uncontrolled asthma with 85% sensitivity. There are also reports in literature that breath VOCs can potentially predict loss of control in asthma. Reliable biomarkers to identify patients with uncontrolled asthma or to predict exacerbations would inform treatment decisions and facilitate disease management. A reliable tool to identify whether a patient is likely to respond to a particular treatment would be an important development. This figure shows data from a study that found that VOCs in breath are able to predict responsiveness to steroid treatment in steroid-naive, mild to moderate asthma patients. With an area under the curve of 0.88, VOCs outperform both FeNO and measurements of eosinophil cells from sputum samples. Promising initial results from the UBioPred consortium shows that VOCs in breath, measured by Alstone Medical's Lone Star VOC Analyzer, could be used to stratify asthma patients into treatment subgroups. In this case, VOCs discriminated between anti-IgE treated and non-treated severe asthma patients with 83% accuracy. In order to identify robust breath biomarkers that can be introduced into clinical practice, breath analysis first needs to be incorporated into clinical trials. One of the challenges in the past with breath analysis has been, how do you collect a high-quality breath sample in the clinical trial setting? This is where our breath biopsy platform comes in. The Reciva breath sampler was developed to enable patient breath samples to be collected reliably and reproducibly, making it ideal for large clinical trials. During sampling, patients just breathe normally while the Reciva tracks their breathing pattern and captures exhaled breath over a period of time. The Reciva traps and stores these VOCs and pre-concentrates them onto sorbent tubes, which are a bit like vacutainers for breath. These tubes are then sent to the lab for analysis. Reciva is deployed in studies at over 90 clinical sites and hospitals across Europe, including the world's largest breath-based clinical trial. Reciva's reproducibility makes it an ideal solution for longer-term longitudinal monitoring of VOC biomarkers, including pharmacokinetic studies measuring changes in the VOC profile after the administration of therapeutic drugs. This figure shows longitudinal data from breath samples collected using Reciva before and after the subject has ingested a surrogate pharmaceutical, in this case a peppermint oil capsule. As can be seen, the levels of peppermint-related compounds in breath were found to increase rapidly after ingestion and subsequently decrease following a washout curve over a period of 8 hours. Making multiple measurements over time allows detection of changes in biomarker concentration that can indicate deviation from a baseline state and reflect changes in the underlying disease activity, helping to identify deteriorating disease control, a successful response to therapy, or an early indicator of adverse reactions to therapy. At the heart of breath biopsy is the FAMES microchip chemical sensor. We originally developed the FAMES chip for the detection of toxic gases and explosives, and FAMES is now deployed globally in a range of industrial and military applications. We have taken this well-established, proven FAMES technology and incorporated it into our Lone Star VOC Analyzer to provide an extremely robust and reproducible platform for the detection of VOC biomarkers in breath within clinical study environments. A key step is taking the rich FAMES spectral data and analyzing it to identify potential new biomarkers. This involves first identifying features, then developing a classifier, then refining that classifier, and finally evaluating its sensitivity and specificity. To facilitate this, our data scientists have developed a machine learning approach for breath data to develop and evaluate classifiers. The most straightforward way to include breath analysis in your clinical study is to use our biomarker services. You simply rent a Reciva breath sampler. We provide full training for the trial nurses to collect breath samples, and then you send the patient breath samples back to our breath biopsy clinical laboratory, where our experts will take care of the entire analysis, including biomarker discovery, test creation, and validation. You pay per sample for the analysis. As part of our biomarker services, we may use our proprietary database, containing thousands of anonymized patient VOC profiles to verify a classification algorithm in silico. This can provide you with early evidence of likely clinical relevance without the need for additional samples or studies. If you are considering initiating a new study, we offer assistance with setup and study design, ensuring from the start that your project is optimally designed to deliver the answers you are looking for. Whether you're looking to identify novel breath biomarkers for diagnostics, or for precision medicine applications such as therapeutic response, patient stratification, or drug toxicity prediction. Alternatively, if you prefer to do the analysis yourself, you can of course purchase a Receive a Breath Sampler and Lone Star VOC Analyzer and integrate Breath Biopsy platform into your own lab. I hope I've demonstrated how VOCs in exhaled breath have enormous potential as biomarkers for respiratory disease diagnosis, phenotyping, and monitoring. Promising results in the field of asthma and COPD indicate that VOCs reflect specific molecular processes that underlie chronic inflammation, making them ideal biomarkers for precision medicine and treatment stratification. We have invested significant effort to develop reproducible workflows for the collection and analysis of breath VOCs that can be used for robust biomarker discovery in large-scale clinical trials. To learn more about how you can integrate breath biopsy into your clinical trials, visit alstonemedical.com/respiratory to download our complete guide to breath biopsy, or get in touch to arrange a discussion with our experts. Thank you for listening to this webinar.